So good afternoon, everyone, and thank you for joining us. My name is Steph Kershaw. I am a postdoctoral research fellow at the Matilda Centre for Research in Mental Health and Substance Use, and we're located at the University of Sydney. I'm also the project coordinator for the Cracks in the Ice Toolkit, and I'll be chairing today's webinar session. So I would like to start by welcoming you warmly to this webinar. It's great to have you with us, and today's presentation is one in a series of webinars which will be focused on crystal methamphetamine, or ICE, Australian community. And this is running as part of the Australian Government Department of Health funded project Cracks in the Ice. So if you haven't already visited the website, I would encourage you to visit www.cracksintheice.org.au. And we always appreciate feedback, so if you have any comments or questions, send them through. So in a minute, I will introduce you to our speaker for the day. But before I do, I would just like to let you know that we will be recording today's session, and we will be making the recording and the PowerPoint presentation available after the session. So I should also let you know that you are in listen-only mode, so we can't see or hear you, but I would like you to direct your attention to the Q&A box, which is of your screen. So if you have any questions throughout the webinar, you can always send them through to us. And we will be having a question and answer section of the webinar where you can ask Mark anything that you would like. So without further ado, I would like to introduce you to our presenter for the day. So welcome to Dr. Mark Greenhalgh. Dr. Mark Greenhalgh is a neonatologist practicing at the Royal Prince Alfred Hospital in Sydney. He has a keen interest in improving the management of babies exposed to illicit substances in the womb, and a large part of this role involves engaging with and managing the mothers and extended families. He is part of a multidisciplinary team at RPA, which provides this service. So thank you so much for joining us today, Dr. Greenhalgh. We are extremely grateful that you have given up your precious time to take us through what is going to be a really interesting session. So I'll hand over to you now to make the presentation.
Thanks, Steph, and good afternoon, everyone. Thanks for the invitation to talk about something which I'm really passionate about, and I hope you find this session useful in your own practice. As Steph said, I'm a paediatrician. I work in inner Sydney at a large city hospital, and I'm part of a big team that manages families where illicit drug use is either part of the family's history or, in fact, an ongoing part of the pregnancy. So this is a slightly paediatric slanted talk, but hope you find it useful. These are the things we're going to go through today. Essentially what we're going to look at is how pregnant women can be affected by methamphetamine use, what risks prenatal methamphetamine exposure places on the newborn, and we'll talk about some management strategies for both the mum and then the mum and the baby following the delivery. And there'll be lots of time left at the end. I'm really happy to answer any questions. A couple of the resources that I'm using today are, of course, Australian government resources. So the National Drug Strategy Household Survey from 2016, which is an Australian government initiative, and also in New South Wales Health. I realise everyone's not from New South Wales, but some of the information I've got is from the 2017 methamphetamine use and related harms in New South Wales document. These are both freely available on the net. Steph's mentioned, this series, which I really do recommend everyone, if you haven't gone through some of the other webinars which are available in this series. There's some really good webinars, particularly there's one on psychosis and methamphetamines, and also the stigma around methamphetamine users. And if you saw Professor Nicole Lee's recent webinar on the effects of methamphetamine use on the body and the brain, you would recognise this diagram, and I've taken it from her presentation. Methamphetamine, of course, is a type of one of the types of amphetamines, and there are 3 types of methamphetamines. Speed, which is the powder form, which in the early 2000s was easily the most common form of methamphetamine that we saw. There's also base, which is a powder form, and of course ice, which this series is all about, which is the crystallized form. You can see from the diagram on the right hand side that without doubt crystal methamphetamine or ice use is easily the most common form of methamphetamine use now. And the most worrying thing about this is that, of course, ice is the purest form of methamphetamine, so it has the strongest purity and therefore probably strongest effect. The National Drug Survey from the Australian Institute of Health and Wellbeing happens every couple of years, and you can see some results from the last 6 surveys on this slide. So in 2016, they interviewed over 23,000 Australians aged 14 and older, and you can see the decreasing trend in tobacco use down to about 15% in 2016, a fairly stable recent alcohol use around 80%. And then when we look at the illicit drugs, marijuana, of course, still the most common illicit drug which is used, ecstasy around 2%, and there seemed to be a decrease in the methamphetamine use down to 1.4% in 2016, but this is 2-year-old data now, and with the increasing availability of methamphetamine on the street, that number would be higher than that now. From the same survey, you can see there's the 1.4% of Australians in this survey who had used methamphetamines in the last 12 months. So remember, this is a survey of 23,000 people, but if that represents Australia as a whole, potentially almost 300,000 people using methamphetamines in the previous 12 months. And of users of methamphetamines, 1 in 5 or 20% using methamphetamines at least weekly, and almost 2/3 now using the purest form, crystal methamphetamine. Of course, methamphetamine use is rarely isolated. Polydrug use is very, very common. Large proportions of methamphetamines users marijuana or other drugs like ecstasy or heroin, and this was an Australian government combination of a few different surveys that were carried out. But you can see polydrug use is a real issue in Australia. That's just a bit of background about methamphetamine, just to set the scene. This webinar is all about ice use in pregnancy, and you may have seen some of the health campaigns such as this one. So methamphetamine abuse and treatment during pregnancy. Maternal methamphetamine may endanger the health of the mother and be associated with a possible increase in birth defects. So there are some of the things we're going to talk about through this lecture. This is from a study, the IDEAL study, which was done in the States a couple of years ago, which is fairly damning, actually. So the IDEAL study reported that up to 5.2% of women used methamphetamine at some point during their pregnancy. Again, Australian data from the same National Drug Household Survey in 2016, fairly representative of our population. You can see up to 50% of women using alcohol before they were pregnant, but then quite a significant drop after finding out they were pregnant. Similarly with tobacco, a decreased use after finding out they were pregnant. And if you look at illicit drugs, and of course this is taking into account all illicit drug use, just not methamphetamine use, about 4 to 5 illicit drugs before they knew they were pregnant, but only a small decrease after finding out they were pregnant. So many women using prior to pregnancy and then through pregnancy as well. And similar trend, this is data from America, and really separated out by age groups here. So the blue and the green bars more representative of the reproductive age, showing anywhere from about 2 to 6 or 7% of women using substances during pregnancy. Admin et al. Published earlier this year a really nice paper which looked at all the inpatient units in America. So they had a population of over 47 million people in this study who had delivered over about an 11-year period. And you can see the trends in amphetamine and opioid use over that time. And they concluded that there's an increasing incidence of amphetamine and opioid use among delivering women, and the associated adverse gestational outcomes indicate amphetamine and opioid use affecting birth represents a worsening public health crisis. You can see here amphetamine in all counties and amphetamine use in the rural counties. So there's no doubt that certainly over the last 10 years, amphetamine use in pregnant women is increasing, and it certainly is representing a public health crisis in Australia as well. One of the reasons I'm very passionate about being involved in this area is these kind of headlines. This was a group from the University of Toronto in 2005 that was studying the effects of crystal methamphetamines, and they published this quite catchy headline: "One hit of crystal methamphetamine causes defects and affects fetuses at all stages of development." You have to remember that crystal methamphetamine is a free radical, and when it gets into the maternal circulation and then into the fetus is very, very vulnerable to damage from free radicals such as crystal methamphetamine. They showed in this study, which they actually did on rats, that it only took one hit of the purest form of methamphetamines to cause long-term developmental issues. You know, this is a real problem for us. We thought we'd just quickly do a webinar poll. So I'm going to show a history, and then Steph's going to put up the options for you to put an answer in, and then we're going to talk about some of the conclusions. So here's a woman. She presents at 29 weeks for her first antenatal appointment. So she's, almost 30 weeks. She's unbooked, and this is an unplanned pregnancy. She has an 18-month-old boy who was removed at birth in view of active drug use, and she has hepatitis C. At the booking appointment, she discloses a recent lapse with use of crystal methamphetamines, which she injected following a fight with her partner. And we're after your gut feeling here. What is your gut feeling around what will happen with this when the baby is born? And these are the options.
Okay, so I've just launched the poll, so it should be visible on your screens. The options are: 1, it depends on what the mother wants. 2, the baby will be assumed into care. 3, the baby will go home with mum. And 4, it depends on how the mother engages over the coming 11 weeks. So we'll just give you another 15 seconds or so to respond to the poll, and then I'll close it off and share the results with you. So Mark, what would you think is your gut feeling with this poll?
Yeah, for me, my gut feeling is there's a lot of concerns in this history, but we've got a lot of time left to make some changes. So it'll be interesting to see what people think is the right answer here, because I don't think there is a right answer.
All right, so let's close off this poll and we'll share the results. So overwhelmingly, people, it depends on how the mother engages over the coming 11 weeks. So there was a 28% group of the participants who voted for that option.
Thanks, Steph. So this is not an uncommon presentation in antenatal units such as ours. So, recent involvement with community services, she's had a child removed before, there's ongoing drug use, she's got hepatitis C. And for me, I think there's a lot of stigma around this population, so the population of methamphetamine using pregnant women. And that's really what I want to talk about in all. So again, some of the stigma around ICE users. So again, this is from that large Australian Institute of Health and Wellbeing study from 2016. This one here, so methamphetamine is now the drug of most concern to the community. So this used to be alcohol, which concerned most people, and now in the general population, methamphetamine is causing the most concern to the community. Still many people are probably thinking it's associated with a drug problem and it can cause deaths, obviously. I really can't stand these type of headlines. So meth babies, just making the stigma around this population, this vulnerable population, even worse. So meth babies on the rise, long-term effects of mums on meth during pregnancy, and then linking it to a journal article. And then there are studies showing that many of the increases are surprisingly seen among people with higher incomes, implying that all of women that use methamphetamines are poor and on the street. This is not true at all. There's a whole raft of women that are addicted to methamphetamines, but there's no such thing as a meth baby. Of course, we're not talking about cocaine, but similar thing, crack baby syndrome. There's no such thing, but it's just all about the stigma around this population. And in fact, if you think about that question, this type of image might have popped up in your own head. You can see, a woman here with probably a second trimester bump, and she's got the tourniquet around her arm and self-injecting. And, my argument is, why aren't we thinking about these women like this? And this is how we would think about the majority of pregnant women. Why aren't we thinking about pregnant women who are using illicit drugs through their pregnancy like this? We have to remember that methamphetamine it's an illegal substance. This is misuse of drugs, but these women are not having a one-off, are not using methamphetamines once off. They're using frequently. They are in the cycle of addiction. And part of our role in health as health practitioners is to advocate for change. And, I'm a very strong believer that pregnancy is a real opportunity to advocate and assist and to support vulnerable women in quitting the cycle of addiction. So for me, the answer for that poll probably is option 4. It depends how she engages. I think, 10 or 15 years ago, most people would have said that baby would have been assumed into care. Now, I would very confidently say, if that mother engages well in the system and is supported and, makes changes, then potentially the baby would be going home with mum. And, that's what we're trying to do if the environment's appropriate. So let's talk about how methamphetamine exposure antenatally can affect the mums. So we see frequently that these women engage quite late throughout their pregnancy. They certainly receive less antenatal care than the general population. And antenatal care is very, very important for all pregnant women. It's a time to monitor the maternal health. It's a time to monitor the fetus's well-being. A lot of things can change throughout pregnancy, so antenatal care is vital. And we know this population often engage late, if at all, and receive less antenatal care. Often the mums have quite a low BMI. They have quite poor nutrition. They frequently have intercurrent infections such as hepatitis C, which may or may not have been previously diagnosed and or treated. And certainly illicit drug use is associated with a higher rate of miscarriages in the first trimester and then subsequently stillbirths as well. We've talked and touched on already the issues around poly drug use, and frequently there are major and complicated social concerns which need addressing and can only be addressed if we can engage these women in the system. And we might talk about that at the end, or someone might want to ask more about how we do engage mums better in our system. But certainly some of the stigma that exists in antenatal clinics often doesn't encourage women to engage to their best potential. This is from Admin again, so published earlier this year in 2019. So a large cohort of patients and a large amount of women who are using amphetamine use identified during pregnancy. There are significant increased complications for these pregnant women. They do have higher rates of preeclampsia and placental abruption. So preeclampsia is really a disorder of blood pressure, which can then in the mum, which can then affect multiple organs like the mum's liver and her kidneys, but also her brain. So preeclampsia is a precursor to eclampsia, which is a seizure disorder in pregnant women. So we know that pregnant women using amphetamines, and shown nicely in this study, have a much higher rate of preeclampsia. They also have a higher rate of placental abruption, which is where the placenta essentially breaks away from the uterus. And obviously that's very dangerous for the fetus, but also can lead to significant complications and death for the mother as well. We'll talk more about increased rates of prematurity, increased rates of caesarean sections, and all the complications that can come with caesareans. But pregnant women who use amphetamines, they have a higher rate of morbidity and death. So, this isn't something we can sweep under the carpet. This increasing public health dilemma, for me, it's all about the increased risks of death and disability to the mum and to the baby, which we'll come to. These are the guidelines from the Australia and New Zealand College of Obstetrics into how substance using pregnant women could potentially be managed. Like most college guidelines, that there's a lot of words. I've kind of just tried to underline some key features for me. Obviously, as I've mentioned, pregnancy is a really, really key time where women can be treated for withdrawal and also supported in quitting the cycle of addiction. These women need lots of information given to them in multiple different forms. They do need a supportive network around them. It's very hard to do this on your own. So involvement of partner and family and extended family and community to support the pregnant woman. And this really, really does need a multidisciplinary approach. Essentially, for me, point 4, there's probably in the wrong order. It probably, for me, should be, drug and alcohol support workers, social workers, mental health workers, midwives, and medical staff potentially as the least important people in supporting. But it's multidisciplinary and it takes a lot of time. But there's serious issues here and serious complications if these aren't addressed. There are potentially 2 stages of a methamphetamine with withdrawal. An initial or kind of crash phase where women come down off the stimulant effect, where they're initially very sleepy, have quite a depressed mood, and tend to overeat, and then that runs into usually after a day or so, quite a prolonged secondary phase of withdrawal, really characterised by fluctuations in mood, lots of cravings, difficulties with sleep pattern, and persistent lethargy. Most of us would have been exposed to some of the psychotic symptoms that women can display as part of their withdrawal as well. And really that leads into how women potentially can be managed antenatally. If you work in South Australia, you would recognise this diagram into trying to decipher which women potentially are better managed in a residential facility or in a hospital facility to facilitate supporting their anticipated withdrawal symptoms. But as I've said, supporting mothers breaking the cycle of addiction needs a multidisciplinary team. There's lots of counselling, lots of support. There's lots of cognitive behavioural therapy, and often being in a hospital facility or a residential support facility can facilitate the use of medications if they're required. And some of the medications that are often used are benzodiazepines for a short-term period, antidepressants, antipsychotics. There is definitely a role for involvement of child protection services antenatally. Here in our district in Sydney, we have quite a good program where we often attempt to involve child protection antenatally in at-risk families. And, again, we're trying to remove some of the stigma that child protection or FACS is there to remove babies. For me, child protection is there to provide more support to these families. And if we can get pregnant women to engage with child protection services antenatally, which has been set up in our district, then potentially we can have a plan in place antenatally about what's going to happen with the baby afterwards. And often that involves the baby staying with the mum with a really good support plan about how they're going to get home together. And obviously, this maternal management doesn't happen in a day or a couple of days. It's ongoing, often up till delivery and then beyond delivery as well. So if we now turn to what happens around the time of delivery, this was, again, a study published out of the States where they have a lot more literature around methamphetamine use. Again, this was a retrospective review in where they identified pregnant women who were using methamphetamines and then tried to match them up to control patients as well. And you can see all of these perinatal characteristics which are significant. So these mums who use methamphetamines, they're at a higher risk of delivering prematurely. The babies tend to have worse APGAR scores at 1 and 5 minutes, and the APGAR scores, a marker of how well the baby is at 1 and 5 minutes. They have higher rates of caesareans, and caesareans have lots of potential complications associated with them, including longer time in hospital. But interestingly, this study showed that these babies have higher rates of mortality and significantly higher rates too, as well as the mums having more obstetric complications, including intensive care admissions for the mums. So, this is really damning evidence that, we have to work really, really hard at supporting and stopping this chain of addiction because methamphetamine use in pregnancy has significant effects on delivery as well, and on both the baby and the mum. So what happens to the baby? This was a really nice study published a couple of years ago, again, from the States. And this group looked at a group of women who were being managed in a drug health clinic antenatally, and matched them to a group of patients who weren't using drugs throughout their pregnancy. So if you look at the right-hand two columns, I don't know if you can see the marker, but these two columns, so you're essentially comparing women who just use methamphetamines to no drug use at all, and then some of the outcomes of the babies. So as I've already mentioned, these babies are often born prematurely or at least earlier than their matched cohort, but also the babies are smaller in birth weight. They have significantly smaller head circumferences, and for me, that's a real worry because head circumferences are a marker of brain growth, and we'll talk about that in a second. And they're also shorter as well. So the methamphetamine exposure is affecting the growth of the fetus, the brain, the limbs, and the subcutaneous fat stores as well. Shah and his colleagues published the IDEAL study, and I just touched on this right at the start. But essentially, this is the largest documented kind of prospective study, which looked at over 34,000 women in 4 sites in America, and then used coding matching to see which of those women were potentially using methamphetamines or who had a positive urine screen for methamphetamines throughout the pregnancy. And you can see, again, some of the complications for the babies. So more of the babies were admitted to the nursery, requiring respiratory support, being born earlier. They weren't able to show any difference in cardiac or in birth defects, in particular cardiac defects in this study, but there's several case reports and cohort series published in the literature about some of the birth defects associated with methamphetamine use. So some of the things that are documented include cardiac defects, this is in the baby, cardiac defects, cleft lip, cleft palate, limb abnormalities, and changes in the brain as well. And we'll talk about that in a minute too. I've put in a slide about neonatal abstinence or acute withdrawal of the baby. To be honest, the literature is not very clear about methamphetamine withdrawal in the newborn. Certainly, if you're a fetus and you're exposed to methamphetamines in the days leading up to delivery, then potentially you can withdraw, and there certainly are documented case series of babies withdrawing to methamphetamines. To be honest, it's not as common as, say, opioid replacement therapy withdrawal, but the symptoms are fairly similar. Babies who are withdrawing from methamphetamines, they're very, very unsettled. They are poor feeders. They don't suck well. They have a really irritable, high-pitched cry and quite loose stools. We know that the rate of neonatal abstinence continues to go up. These babies often have quite prolonged admissions in either a postnatal ward or a nursery. But there's no real tool to, I guess, to monitor withdrawal to methamphetamines. I'm sure many of you have heard of the Finnegan's score chart or whatever you want to call it. You know, this is an opioid based neonatal abstinence scoring tool, so probably not appropriate for methamphetamine exposure. There's a few new tools available. One is called the Eat, Sleep, Console. I'm happy to talk about that at the end. Again, management of withdrawal to methamphetamine is not easy, and we'll talk about how, you know, we should be encouraging these babies and mums to be together. But, you know, in terms of pharmacotherapy, obviously opioid treatment is not appropriate. This is not an opioid withdrawal, so we have to think about potential other ways of managing methamphetamine withdrawal. And some of the medications which potentially could be used are things like phenobarbital or potentially benzodiazepines as well. But, you know, there's a lot of other things that can be done before pharmacotherapy treatment for withdrawal. I'm really interested in looking at, you know, how these babies and mums compare to the general population in some of the things that are normal for women after delivery. If you look at the bottom red circle there, these women often have lower rates, significantly lower rates in this study from Shah, published in 2012, lower rates of breastfeeding. And I'm going to talk about breastfeeding in this population in a second. And I guess not to be unexpected, higher rates of child protection involvement and higher rates of assumption of care when compared to, you know, the standard population. So how do we manage babies and families who are in this situation? Well, for me, I think it's how we manage all babies and mothers who have just given birth. The primary aim should always be to keep the mother and the baby together. Separating the mother-baby dyad is a recipe for disaster in most cases. And most hospitals, certainly our hospital here in Sydney, the buzzwords are family-centred care, encouraging mothers and babies to be together, breastfeeding accredited. So for me, as long as the safety of the baby is not compromised, we should be aiming to keep the mother and the baby together. And there's a few things that can be done to facilitate that. We'll touch on them in a second. There's often a question about whether it's appropriate that these mothers breastfeed. And certainly our approach here is that if the mum's been well engaged in our service, or she's been in one of the local rehab facilities antenatally, or we've seen, a recent negative drug screen, urine, but usually it's around engagement, then we should always be encouraging these women to breastfeed. Of course, it's different if we know the mum has used just prior to delivery, or she shows a positive urine for methamphetamines. Methamphetamine does come in quite high concentrations into the maternal breast milk. So obviously it's not a good idea if the mum's recently used for her then to be breastfeeding, because there will be quite large concentrations going over to the baby. But in general, in the woman who is well engaged and well supported and who we know or has been in rehab, it's all about keeping the mum and baby together, encouraging breastfeeding. These women need large volumes of support. They need lots of intensive midwifery support. And lots of the time, this is for encouragement that they're doing the right thing, that they're doing a good job. And for that, we need all of our midwives and our nursing staff and all of the staff that are on the floor managing these patients to be on the same page in terms of keeping the mums and babies together and encouraging the mother-baby dyad. Certainly here, we try very hard. We're in a large public hospital in the centre of Sydney. We try very hard for these women to be in a single room rather than a shared postnatal room, so that they can have more privacy, but also so that midwifery support can be more patient-focused on this family. And we try very hard to keep them in hospital for a longer period of time than the average postnatal woman, just so that we can get all of the support, the social work support, the drug health support, and a good discharge plan in place before mums are discharged with their baby. We've talked about withdrawal. Obviously, monitoring withdrawal is a good thing. Remembering that the Finnegan's tool probably isn't the right thing to be using if you're monitoring for methamphetamine withdrawal. And not standard practice, but in some hospitals, ours included, we tend to do a head ultrasound on babies where there's been antenatal methamphetamine exposure, because there is documented literature around some of the changes to the brain in terms of ischemic changes that can occur into the fetus. And for me, it's more about having a baseline head ultrasound for these babies. So we've got something to work with moving forward in terms of their development. We'll talk about that in a second. So just to summarise those last couple of slides, aiming to keep the mum and baby together, multidisciplinary support, lots of encouragement around being a mum and engaging with her baby, breastfeeding if appropriate. There are some dedicated mother-baby units around the world where potentially these mums and their babies get more, targeted support. It tends not to be a standard practice in Australia. We have a dedicated mother-baby drug health unit. But, they are a very, very good idea. Just the last couple of slides that I wanted to talk about. How does prenatal methamphetamine exposure potentially affect children moving forward? There are 4 areas where methamphetamine exposure as a baby in the womb can have problems. physical, learning, behavioural and emotional. The physical effects are probably the smallest. There certainly isn't an increased rate of cerebral palsy or other kind of movement disorders. Often these children tend to have clumsier general gross motor abilities, and they might have movements as an infant which aren't as smoothly. Certainly, these children often have lower IQs, and behavioural-wise and emotional-wise, there's been how these children have smaller brain volumes when MRIs are done, and how this correlates with poor attention, poorer memory. But also, this was a really nice study around how prenatal methamphetamine exposure at 5, when parents are asked a questionnaire, significantly there are more reports of these children being depressed, withdrawn, being more aggressive, having sleep problems. And then when these same children were seen at 6.5 years of age, having quite a lot of issues in terms of poorer memory, poorer attention, less concentration ability. So just to summarise some of the things that we've touched on, amphetamine use in pregnancy continues to occur. We really have to change the stigma around this patient group. Prenatal methamphetamine exposure can harm the mum and the unborn baby and can cause long-term consequences to the infant development. These families need lots and lots of support. They need ongoing follow-up and good strategies to encourage change. Pregnancy is exciting, it's empowering. Unfortunately, addiction can compromise a woman's safety, but I think there is hope for recovery, and we should be making lots of help available for pregnant women suffering from addiction. And I'm really happy to take any questions. Thank you. I can't hear you, Steph.
Hi, Mark. Sorry, can you hear me now?
Yeah, sure can. Thanks.
Okay. So thank you so much for that really interesting and practical webinar about the effects of ice in pregnancy and the effects that it can have on the child. But also, you know, it's important to challenge the stigma, support these women because they are in a period of change, and it's a great opportunity to encourage them to think long-term about their health. So quite a few questions have actually come from Mark, so be prepared. So firstly, do you think women engage better in a specialist antenatal clinic or a general obstetric antenatal clinic?
Yeah, I mean, that's a really good question. I think in the ideal world, a specialised antenatal clinic where all of the support people are available, such as drug and alcohol support workers, social workers, as well as, you know, mental health and midwifery, obviously. I think in the ideal world, there would be a specialised clinic separate to a general antenatal clinic. General antenatal clinics, as we all know, are chaotic at the best of times. That doesn't always suit these women. These women need flexibility and also time, but also services and encouragement to engage. So, you know, I think if I had my vote, if I was the Premier, I'd be rolling out dedicated antenatal clinics for these women for sure. Yeah,
that's great. I've got another question. I'm not sure how easy it's going to be to answer, but do you know of any research that is about hearing loss in children, either unilateral or bilateral, as a cause of the mother using methamphetamine in pregnancy? Is there any evidence or suggestion that that's an effect?
I don't think there's any I don't think there's any really good evidence. There are certainly some case reports of hearing loss in babies that have been exposed to illicit drugs in the womb, but I haven't seen any that have been just methamphetamine exposure. It tends to have been poly drug use.
Yeah.
I mean, luckily in Australia, all babies have a hearing screen before they go home from hospital. So, all babies will get their hearing checked anyway. I don't know that it's hard evidence around methamphetamine use causing that, though.
Okay, yeah. And I guess there are other factors that can influence hearing loss as well.
Yeah.
So
hearing's difficult. Yeah.
Yeah, directly. Someone was interested to know how recent the drug use has to be until the mother can breastfeed. So basically, how long does it take to come out of their system? So if you 2 days ago, are you still okay to breastfeed, or does it depend on the urine screen?
Yeah. What we do here, so if a woman is keen to breastfeed, and that's what we're encouraging, but she has, she admits to using methamphetamine the day of delivery or the day before, or she has a positive urine, usually what we'll do is get her to start expressing so that her supply continues to come in, and we just dump that milk. So we throw that milk away until we see a negative urine. So usually it's within 48 hours.
Oh, okay.
Yeah, so it's actually not that long. But again, the encouragement should be, if the mum's keen to breastfeed, we need to start the expressing so she doesn't miss out on the first couple of days to get her milk supply going. And then, we can usually do our urine and get results back, hopefully within a day or so. And then as soon as it's negative, then, the baby can start going to the breast.
Yeah, that sounds like a really good plan. Do you know of, or have you at RPA ever considered a telephone support line for women who are keen to quit drug use in pregnancy?
We don't have a dedicated line for that at RPA or in our district or in New South Wales. There are certainly general support lines for addiction and for change available in Australia. They're certainly not dedicated for drug use in pregnancy. But I agree. These women, they need multiple methods of engaging in the system. A phone line, they're quite expensive to keep those going 24/7. Certainly we don't do that here.
Yeah, but I guess maybe if that's something that one of the other AOD services who do run phone lines could potentially do. And I do know that there's a list on Cracks in the Ice of phone lines for anyone who's seeking drug and alcohol help.
Yeah.
Another question is, do you know what the impact on the unborn child is if the mother goes through withdrawal during her pregnancy? So withdrawal process upsetting, maybe?
Yeah, no. So the impact on the fetus is caused by the methamphetamine hit.
Okay.
It's not the withdrawal that tends to cause issues to the baby. So the damage to the fetus's brain, for instance, is around the methamphetamine itself, not the acute withdrawal. The acute withdrawal can certainly cause problems for the mum, which is why frequently these women are often admitted to a hospital to manage the withdrawal appropriately.
Yeah. Okay. So, in your personal experience and when you're patients, how do you maintain a non-judgmental approach? And I guess this is looking for some maybe practical tips or languages that they could use when people to make sure that they feel, you know, like not being judged or stigmatized?
Yeah, I think that's a really good question. I think there's a really big place for honesty in our system. I try to be very real with my patients. I acknowledge that, potentially drug use has been a problem for them during their pregnancy, but also acknowledge, the steps that they've taken or are committed to taking to change, but also how, as a clinician, I'm going to support their baby, them as a family, how we're going to kind of continue to offer support once they're discharged home, and that we actually care about them. I rarely meet women who don't want their baby. At the end of the day, most pregnant women want their baby with them, and they will do anything in their power to get their baby.
Well, that's good to know. And it's always important to use non-stigmatizing language when you're engaging with clients as well. Yeah. And I think, everyone appreciates a bit of honesty.
Yeah, definitely. Yeah.
What do you know about the eat, sleep, console cycle?
Yeah. So the eat, sleep, console is a tool coming out of the States now around assessment and management of withdrawal. And it's putting more of a focus on non-pharmacological methods of managing babies who are withdrawing, whether it's withdrawal to opioid or methamphetamines or whatever. But it's certainly simpler than the Finnegan's score. It's less of a checklist and more of a focus on encouraging the mums to have skin-to-skin with their babies, to feed their babies, to wrap to their babies, to support their babies. The non-pharmacological methods before kind of jumping into medication management of withdrawal. It hasn't taken off in Australia yet. I don't actually know anyone that uses the Eat, Sleep, Console tool in Australia yet, but I think we're certainly looking at that at the moment. It's starting to get some ground in America, and I don't think it'll be long before we're using some different assessment tools.
Yeah, great. Well, hopefully America will show some good data and can pick it up in confidence and use it.
Yeah.
So I have two other questions. Are you happy to keep going?
Yeah.
All right. So there's a question about someone who's seeing increasing young women in mental health who are being legally prescribed dexamphetamine. And this person wants to know if whether dexamphetamine causes similar issues as methamphetamine in pregnancy.
Yeah.
So they are chemically different, but do you see similar effects?
Look, potentially yes. I think, of course, lots of young people, teenagers are on dexamphetamines for ADHD and attention deficit disorders now. Agree, chemically different, but potentially, under the same subgroup as of amphetamines. So, could have the same effects. Yes.
Okay. I guess we'll just also have to wait and see what comes out in the literature over the next
year. There's not a lot of literature about that, but I think that it's going to increase moving forward. I mean, the whole thing about methamphetamine, crystal meth, is that it's the purest form. So, potentially dexamphetamines would be are not as pure and therefore, have less effect, but, we wait to see.
Yeah, great. So one last question. In your presentation, you suggested that AOD workers or social workers are an initial point of contact for pregnant women who use ICE rather than medical professionals like nurses, doctors. Is there a specific reason or is it just...
Oh, look, I think in general, In general, what these women need is support. They need strategies for change. They need a contact point. And for me, social work and drug health workers provide that. Of course, as I alluded to, the antenatal care is vitally important to that. So I'm certainly not minimising how important midwives are in this whole process. And there are lots of places, especially regionally, where midwives will be providing all of this drug health support. And anyway, where there's other support available, I think in terms of change, we all have a role, but I think social work especially can be really key in helping to manage these women.
Okay, great. Well, thank you to everyone who sent through questions today, and I'm sorry if you didn't get your question answered, but please feel free to email us at cracksintheice, and we can always pass them on to Mark or try and email them ourselves. We will be putting on more webinars throughout the year, and new resources will be going up on Cracks in the Ice. So I'd encourage you to subscribe to our email list at cracksintheice.org.au. And I'd also especially like to say a big thank you to Dr. Greenhalgh for joining us today. It's been a really interesting and engaging presentation. So thank you so much for taking the time.
No worries. Thanks for having me.
Speak to us. All right. Well, I wish you all a great day and hope you found this session informative. Thank you.